Okay. So our topic for today, ito antidepressant poisoning, involves what we call second generation antidepressants. If you still remember, yung nauna, TCA poisoning, they are what we call, they are the first gen to be developed. So because of their toxicity na pinag-aralan na natin, uh, gumawa sila, or they um, founded new antidepressants na second gen, which are this one. So ano ba sila? So these are SSRI, SNRI, or what we call atypical antidepressant. When we say atypical, meaning they are not classified. Andun yung parang ano sila, miscellaneous or others, something like that. Okay? SSRI, I think familiar na kayo sa mga to. And SNRI, may ano naman kayo, di ba? You have your neuro subject, selective serotonin, and the other one is serotonin norepinephrine reuptake inhibitor. Again, they are classified as second generation. And they are used in the treatment of depression, anxiety, and also for smoking cessation. So, since they are second generation, they are much safer to use than TCA and MAWIs. Okay? But, since we're talking about CNS, we're altering CNS function, meron din silang serious effects such as can also cause seizures and hypotension. Okay? So we'll go first with the SSRI. Short background, they are introduced late 1980s. Okay? So before 1980s, ang nagagamit lang the practice are TCAs and MAWIs for depression. Okay? So they are fluoxetine, sertraline, Zoloft, paroxetine, escitalopram, and citalopram. So in practice, ang uso ngayon na nakikita natin, si sertraline and si escitalopram. If you are if you are recently trabaho sa practice, yun yung nakikita natin for depression. So we take note here, escitalopram and citalopram are structurally different from the other SSRIs. In return, they are may potential toxic sila in overdose. Okay? So itong this one is fluoxetine, structure of fluoxetine. Okay? So in general pala, if you're talking about antidepressant, in studies, there are no single antidepressant medication na the best treatment kagad for every patient. Meaning it's more like a trial and error in prescribing antidepressant for a specific patient. Okay? So, ang sabi nila, in general, 40 to 60% of patients will have a positive response to the first antidepressant medication they are prescribed. Okay, that's very low, no? 40 to 60 lang. Meaning, there's a higher chance na be effective sa kanya yung unang antidepressant therapy. And also, the therapy, it includes a long duration of therapy. Months and weeks ang therapy. Okay? Okay. Let's go into mechanism of toxicity. Do you have questions pala? You can ask the public chat or you can use your mic. For the mechanism of toxicity for SSRIs, if you still remember kung saan galing si serotonin, it is from the amino acid tryptophan. Diba? So, tryptophan is converted to 5-TP and then converted to 5-HT, which is serotonin. So, in general, serotonin consists of 7 general receptors. Dami, no? But wait, there's more, with a total of 14 different receptor subtypes. Gano'n ka-broad ang coverage ng neurotransmitter na serotonin. Aside from the CNS, it also covers sa peripheral. Okay? So, their MOA inhibits the reuptake mechanism of serotonin in the CNS neurons by selectively blocking SERT. What is SERT? Hindi ito yung yung pang migraine SERT yun, di ba yun? SERT is serotonin receptor transporter. Serotonin transporter lang. Okay? Si serotonin transporter kasi ang ginagawa niya in normal process, normal physiology, it yung serotonin na nasa synaptic cleft na ready for binding, yung sobra, tina-transport niya pabalik sa presynaptic vesicle for degradation. Meaning, siya yung nagta-transport or siya yung main transporter for reuptake. Okay? So, blocking it will increase serotonin concentration sa synaptic cleft, which increases the stimulation of serotonin receptors. More serotonin in the synaptic cleft, meaning more stimulation of its receptors. More binding, more serotonin. Okay? So, ang maganda sa SSRI, that's why they are less toxic with TCAs. They are less effective at blocking or less to no effect in blocking NET or the norepinephrine transporter or the reuptake of norepinephrine. In return, they are less likely to be able to antagonize muscarinic, histaminergic, and adrenergic receptors. Meaning, walang masyadong action when it comes to these effects. Adrenergics can either be from cardiovascular, okay? Histaminergic, more of the CNS. Okay. Proceed. Okay, these are some of the examples of this table is for examples of serotonin receptors. So these are the main 7 families of receptors. Wala pa din yung subtypes So in general lang to. And their effects. So if you can see here, 5-HT1 and 2 are more involved in behavioral effects. So usually itong dalawang to ang affected sa mga antidepressants. If you check HT3, nausea and anxiety, if you familiar with the mga drugs natin na for vomiting, they target serotonin HT3. Okay? Okay, what else? Okay, ba't ganon? Sayang naman yung animation ko. Ganyan siya kaagad. Okay, move on. This is just a representation kamukha nung sa TCA natin. So in SSRI, again, it blocks the SERT or the serotonin transporter for reuptake. So once na reuptake, babalik yan sa presynaptic for degradation by MAO. Okay? Inhibiting the reuptake, again, increasing the serotonin, mga serotonin to, in the cleft, and increasing binding. So, papasok yan. Pasok. Meaning, increase in serotonin in the body or serotonin effect in the body. Okay, ganun lang. Okay, wait lang. Aside from, di ba, we're talking about 7 serotonin receptors. Okay, madami kasing use ang serotonin, di ba? Aside from the mood, sa personality, sa appetite din, wakefulness, emesis, temperature regulation, sexual behavior, that's for sa CNS or sa brain. Peripherally, serotonin can also regulate vascular tone, GI motility or peristalsis, and can also be found in platelet activation. Okay, sinabi ko lang yung mga specific ginagawa ni serotonin, no? Okay. Kinetics of SSRI, they are rapidly absorbed with a peak serum concentration within 6 hours. So majority demonstrate a high degree of serum protein binding, meaning, again, if you see a high degree of serum protein binding in a drug, it is prone sa drug interaction. Okay, lalo na if the other drug is highly protein bound. So metabolism, they are mainly metabolized in the liver. So tingnan nyo to. Their half-life in general is 20 to 30 hours. Tagal, no? So that's why in overdose, SRI elimination times are further prolonged by the saturation of metabolic enzymes and by delay absorption, especially for sustained release preparation. Okay, these antidepressants, if you check in the market, some of them are in sustained release form, extended release. Okay, they are modified tablets. It's because of their potential overdose. So ginagawa nila, in-extend na lang release na for the patient to um tawag dito, para isang beses na nilang niya i-take within the day, something like that. Okay? So, the main problem is that because of their type of preparation na ganon, pag overdose ang pinag-uusapan, meron silang delayed absorption because of that preparation. Okay? Delayed release, sustained release, extended release. Okay? So, for example, fluoxetine metabolism yields an active metabolite, si norfloxacin, which has a half-life of 4 to 16 days. Ganun siya katagal. Okay? Excretion, they are renally excreted. So, these are some of the SSRI na may metabolize through CYP450 with their specific types. So, fluoxetine, CYP2D6, fluvoxamine, CYP1A2, CYP2C19, paroxetine 2D6 and 2B6, and sertraline 2D6. So, if you majority CYP2D6. Okay? Meaning these are drugs that are prone in, again, drug interaction. Okay. Now, we go to clinical features. Do you have any questions pala with regards to kinetics ng mga antidepressant? Okay, wala. Clinical features. So, there are many studies na nagsasabi na the ingestion of SSRI are less fatal in overdose compared with the other antidepressant. It's because of SSRI have a wide therapeutic window. Meaning, kahit lumagpas ka sa therapeutic window, or I mean, in higher doses, pwede pa rin hindi ka lumagpas within the window. Kasi it has a wide window. Except, again, with escitalopram and citalopram. So, if you sum up in the daily dose, ingestion of up to 30 times the daily dose typically produces minor or no symptoms. Meaning, if nagtitake ka ng 1 tablet of fluoxetine, for example, if you take it 30 times the normal, can all produces minor lang or sometimes no symptoms. So, ingestion of 50 to 75 times the daily dose can cause, ayun na. Start na tayo with the CNS effect, vomiting, mild central CNS depression, and tremor. So, fatalities naman, they are recorded or reported with extremely large doses. Meaning 150 times daily the dose. Sobrang laki nun, di ba? Or, sometimes, may presence, no? Co-ingestants. For suicidal patient, sometimes since they are antidepressant, no, they take it with alcohol and benzo. Okay. So, okay, now that's for the general features of SSRI overdose. We go to the specific features, which is, again, we're talking about serotonin, increasing the serotonin in the body. In overdose, it can cause serotonin syndrome. I know every one of you is familiar with serotonin syndrome. Tama ba? Okay. So, it is caused by excessive stimulation of the main two um, serotonin receptors na si 5-HT1A and si 5-HT2A. So, in general, it manifests with autonomic instability, mental status change, and increased neuromuscular tone. Again, caused by overstimulation of the two receptors. So paano ba siya nangyayari? O how will it occur? Typically, combining two or more serotonergic medication, okay? Two or more, it can also occur, again, ito yung pinakasikat na drug interaction that cause serotonin syndrome, an SSRI and MAOI inhibitor, diba? Kasi both of them promotes increase in serotonin in the body. It occurs several days to 1 week after the addition of new serotonergic agent, or after the dose of serotonergic agent is increased, meaning delayed response, no? It's because also of the half-life of these drugs. So I delayed response. Tagal bago, several days to 1 week bago mag-manifest. So these are some of the most common drugs that can cause serotonin syndrome: sertraline, paroxetine, and fluvoxamine. You have questions? Okay, we go to specific manifestation. For neuromuscular tone, may nagkakaroon ng muscle clonus. Sometimes presence also of ocular clonus. Again, clonus is what? Jerking, twitching, something like that. Movement, muscle movement. Agitation, diaphoresis is also tremor, hyperreflexia, muscle rigidity, and hyperthermia. Hyperthermia usually more than 41.1. And since we're talking about autonomic instability, merong hypertension and tachycardia. There's also the presence of agitated delirium. So the end game ng serotonin syndrome, if not treated or not addressed, the patient will develop rhabdomyolysis because of the hyperthermia, because of the neuromuscular tone. So sobrang clonus. If a patient develop rhabdomyolysis, it can also develop renal failure because of the release of what? Creatine in the body. The patient is in renal failure, meaning there's a retention of electrolytes, will then cause metabolic acidosis. Metabolic acidosis in return can cause metabolic derangement in the body, can cause seizure, and DIC, or disseminated intravascular coagulation. Okay? Those are the dangerous characteristic na pwede mangyari sa patient with serotonin syndrome. Okay, after serotonin syndrome, overdose of SSRI can also cause cardiotoxicity. Specifically, si citalopram. Citalopram is the most cardiotoxic SSRI with moderate at 600 to 1,900 milligram ingestions. For example, this is an average dosing of citalopram. So, sometimes may patient na nag-take ng 40 milligrams once a day. So, at 600 milligram, cardiotoxic dose na yan. Or there's a possibility that it will promote cardiotoxic. Okay? So, the toxic metabolite or the cardiotoxic metabolite of citalopram is dides-methylcitalopram. Okay? And gaano ba siya ka-cardiotoxic? What are the manifestations? So, sa cardiac conduction disturbances. Talking about conduction, it's either prolonged or widened widened QRS interval and or QT prolongation. Okay? Okay. The third one, the clinical features of SSRI overdose is neurotoxicity. Again, nandiyan na naman, citalopram. Again, citalopram and escitalopram, they differ from their structure from the others. That's why they're toxic. Citalopram is the most common cause of seizure in single agent ingestion reported na mga antidepressant in poison centers in the US. Okay? The risk of seizure is dose dependent. So again, ingestion of 1,600 to 19 appears to induce seizure. Okay? So si escitalopram, ang kapatid ni citalopram, it's pharmacologically active as enantiomer of citalopram and a more potent inhibitor of serotonin reuptake. So it mimics citalopram and consists primarily of serotonin syndrome and QTC, interval prolongation. Yun din yung isa niyang feature. In the difference between them and citalopram, escitalopram have greater serotonergic toxicity but less cardiac toxicity. Okay? So meaning it has a higher risk of producing or developing serotonin syndrome compared with citalopram. Citalopram more on cardiotoxic. Okay? Oh no, di nakikita. So, ang title nito is Differential Diagnosis with Other Toxidrome. Diba, ang dami na nating diniscuss sa toxidrome. We have discussed sympathomimetic toxidrome, which is nandun ang methamphetamine and cocaine. Okay? Anticholinergic toxidrome, opioid, and serotonin syndrome. If you check if you see the bold letters, parehas anticholinergic when it comes to vital signs. If you see, hyperthermia, tachycardia, hypertension, takip niya. Hyperthermia, tachycardia, hypertension, takip niya. And the pupils, same, mydriasis. Difference lang din nila sa mental status, agitation, delirium. Dito more of confusion. Okay, pero if you check din, parang same lang din. So we can differentiate it with the presence of tremor, myoclonus, hyperreflexia, clonus, and muscle rigidity. So remember, in serotonin syndrome, meron siyang neuromuscular term na nito, neuromuscular tone na manifestation. That's one of the differential diagnosis in determining if it is an anticholinergic toxidrome or a serotonin syndrome. Okay? Okay, they're done with SSRI. Next natin is SNRI and other atypical antidepressant. Do you want a short break? Bigyan niyo ako 2 minutes, ha? Or do you want to proceed na? By the way, we're halfway done na. Give me 2 minutes. Okay, we're now done with SSRI. We'll now proceed with SNRI and other atypical antipsychotics. Okay. So in SNRI, since serotonin and norepinephrine reuptake, dual action. So sa dual action niya, meaning they exhibit greater toxicity than SSRI. Okay? So they're also used in depression, anxiety, and smoking cessation. So si venlafaxine, desvenlafaxine, duloxetine, and milnacipran, sila ang NRI. They inhibit serotonin and inhibit SERT and NET reuptake. Si bupropion, alam ko you're familiar with this drug. It's a weak inhibitory of both norepi and dopamine with no effect sa serotonin. Okay, so meaning more on adrenergic effect ito, si bupropion, which is used for smoking cessation. On the other hand, mirtazapine is potent presynaptic antagonist of central alpha adrenoreceptors, alpha 2 and alpha 1. Meaning adrenergic also, which yung alpha 1, alpha 2 kasi it promotes monoamine release. Related dyan kasi again, si monoamine is the one who recycle or depletes or tawag dito, involved in the degradation of the monoamine neurotransmitters, which are NR-epi, si serotonin, etc. It also acts as antagonist of both sa HT2 and HT3. Okay? So, in the mechanism of toxicity, norepi is from the amino acid tyrosine, di ba? So, ito lang ang pinapakita ko dito, the ratio of SERT and NET inhibition. Again, SERT is serotonin transporter inhibition, and NET is norepinephrine transporter inhibition. If you see, tingnan nyo, si venlafaxine has a 30 inhibition ng serotonin and 1 lang. Actually, 1 lang halos lahat. Meaning weak lang ang NET inhibition nila. If you also remember, TCA, ang main MOA niya is blocking both SERT and NET at the same ratio. That is why they're toxic. And SNRI are less toxic because of the ratio. And also, mas konti and lesser NET inhibition. Okay? So, si milnacipram, maganda sa kanya, 1:1. No? Okay, let's proceed. Okay, this is just an illustration of SNRI. Reuptake by NET. Tingnan nyo, dito, isa lang ang norepi kasi, di ba, based from the ratio, only 1 lang yung ratio nila. Increasing the amount in the synaptic cleft, again, increasing the amount of binding sa neurons or increasing the amount in the body, norepi and serotonin. Sayang naman yung effort ko sa animation. Okay, but anyway. How about for the others? So, si bupropion is stimulant that inhibits reuptake of, again, dopa and norepi. Remember this, they are norepi, adrenergic. In the other hand, trazodone and mirtazapine produces peripheral alpha adrenergic blockade. Okay, di ba? It blocks central alpha receptors. Meaning, it results in hypotension and priapism. I want you to take note, none of the drugs in this group has significant anticholinergic effects. SNRs, ano yan, in general, SRI, SNRI, and atypicals. Okay? Kinetics of SNRI and atypical. So, absorption, they are rapidly absorbed, and sa metabolism, more on hepatic clearance. Si venlafaxine is metabolized to its prodrug, that's venlafaxine via 2D6. And then venlafaxine undergo glucuronidation. Okay? Duloxetine naman, it's via CYP1A2 and CYP2D6. And si milnacipram, ang unique sa kanya, hindi siya nag-undergo this. Hindi siya more on hepatic elimination. It's more on renal elimination. In overdose, most atypical antidepressants have increased bioavailability and a prolonged half-life. Again, this is because these drugs are formulated to have a extended release action, extended or and others na the like. Okay, let's go directly to the clinical features. So, overview lang, majority causes immediate mild to moderate CNS toxicity. Yun ang maganda sa kanila. Okay? And bupropion can cause agitation and seizure. Seizure because of its effect in adrenergic sa norepi and also sa dopamine reuptake. Venlafaxine, take note also, can cause cardiac adverse effect and also seizure. And since they also block SERT or inhibit SERT, there's a possibility also for the development of serotonin syndrome. Lalo na when combined with other drugs, drug interaction with other serotoninergic agents. Okay. Seizures. Again, bupropion and venlafaxine. Common. Okay? Bupropion overdose involves, ayan, sabi ko, meron kasing immediate release, formulation, meron din silang sustained release, extended. So, in those 600 or more, doon nakikita ang seizure in bupropion. The seizures can be any type of seizure, okay? Except for status epilepticus is rarely seen, okay? Venlafaxine overdose induced seizure occurs naman patients who ingested more than 900 milligrams. Excuse me. Second one, seizures. Second one is cardiac effect. So madaming there are a lot. So ginawa ko na lang sa table. So their effect is QTC prolongation, tachycardia, and hypertension. Okay? For if you can see, tachycardia and hypertension, itong mga to may effects with regards to the adrenergic, no? Sa norepi uptake, if you see the drugs. And si bupropion is present sa tatlo. So, toxic siya in overdose. Okay, let's go now to management. Management, this is in general, meaning it is applicable sa SSRI, also applicable sa SNRI, and to atypicals. For the serotonin syndrome, what is the treatment for serotonin syndrome? Of course, to discontinue serotonergic agents. And because of they are agitated, so we need to sedate them using benzodiazepine. If benzodiazepine and supportive care fail to improve, cyproheptadine is a serotonin antagonist. Okay? Siya ang actually parang antidote for serotonin syndrome. But kasi if benzo naman, nag-improve naman yung agitation with benzodiazepines, pwede nang hindi na gamitin cyproheptadine or methylsergide. The mo of cyproheptadine is with regards to histamine 1 receptors. And then meron din siya non-specific for HT1A and HT2A serotonin receptors. Okay? That's why it is a serotonin antagonist. And for the hyperthermia, kailangan silang i-sedate. I-sedate and kailangan silang i-intubate. So, the neuromuscular blocker na recommended for intubation is rocuronium. For autonomic instability, which is hypertension and tachycardia, dapat short-acting agents ang gamitin, which example is esmolol and nitroprusside. Okay? And if we're talking about, again, hyperthermia, because of autonomic instability, hindi siya pwedeng i-treat with antipyretics. Kasi it's hindi doon yung main culprit. Okay? Okay. And also, again, if you remember, the use of succinylcholine in hyperthermia is not recommended because of the risk of rhabdomyolysis. Okay, seizures. For seizures, the first line, again, si benzodiazepines. It's either you can use diaz or lorazepam. And if the first line fail, we can use barbiturates, either phenobarb or pentobarb. And if refractory pa rin sa benzo and barbiturate, it's time to use propofol, the milk. Again, propofol should be administered by anesthesiologist or a critical care specialist. Propofol is used successfully to treat seizures due to antidepressant overdose that are refractory with benzos and barbiturates and can be used as an induction medication for RSI. Okay? That's why it is used. Pero again, it is used only if the patient are refractory to benzo and barbiturate. RSI again is rapid sequence, intubation. And lastly, I think this is the last slide. For cardiac toxicity, if there's the presence of sodium channel blockade, so most probably it's caused by venlafaxine. So signs niya, it's one of the signs is a prolongation of QRS complex with more than or equal to 120 meter per second, terminal R wave of 3 mm or more in the lead AVR. I think you do not need to memorize the mga to. If there's a presence of sodium channel blockade, okay, which is seen, di ba, in TCA overdose, the first line is sodium bicarbonate. Okay, ganun lang kasimple when it comes to sodium channel blockade. And for QTC prolongation, we need also, aside from its first line na Magsul, alam nyo na yan, di ba? Magsul ang first line with QTC. We need to check also for electrolyte imbalance. What are the electrolyte that can contribute or that may precipitate QTC? Hypokalemia and hypocalcemia. Kindly also add hypomagnesemia. Add ko na lang yun dun sa upload kasi. Okay, do you have questions? Can you now differentiate TCA overdose with the SSRI and SNRI? Do you have any questions in public chat? Very easy lang, no?